Good evening, all the aspirants present here. So, we have moved towards the last session where we'll be completing two domains. And the speaker for this session is Dr. Sangshaptak Saha, sir. So, you may continue, you may start presenting your presentation. Thank you.
Yeah, good evening. So today's topic is basically regarding the EDIC part 1 crash course. So today we shall be discussing a few MCQs and along with that a bit of very brief theoretical revision will be done. So one domain today, these are the two domains today. The first domain is regarding coronary critical care. So that domain actually was taken up by me. So those who have attended the full sessions, they know what to expect from there. We shall discuss mostly some MCQs and the very basics. I shall be going through both the PPTs, just a few, no explanation or anything, but just for revision, we shall go through it. And the second domain was regarding environmental hazards and toxicology. Environmental hazards, I did not find that many MCQs to have come, or but yeah, toxicology is definitely a very important part. So that we shall discuss. Toxicology also, it will be a few MCQs followed by your yeah a few bit of a theoretical discussion also. So in between, I shall be asking some of the candidates or maybe one or two questions because I know despite urging for interactive sessions, people are not that interested to be interactive during the sessions. So I shall not be asking the regular MCQs. I shall be asking the question, telling the answers also. But yeah, in between, I shall be asking a few questions. Somebody is interested, they can speak up, or else I shall give the answer after a couple of minutes. Fine. So the first we shall be discussing a bit of cardiology EDIC 1 MCQs. So 76-year-old woman was seen in the acute medicine follow-up clinic. She had been admitted palpitations at time of admission. Her 12-lead ECG showed normal sinus rhythm. So basically, the patient had a normal sinus rhythm. She had this episode a few times before and they always revert spontaneously. She had no past medical history. An outpatient 24-hour ECG is performed which showed a 10-minute run of AF. So the net result of this question is that the 76-year-old woman had a normal sinus rhythm, but a 24-hour ECG showed a 10-minute run of AF, right? The patient did not feel palpitation at this time. So basically asymptomatic patient, but one episode of palpitations have taken place. So now they're asking what is the first line of management. So you see, this is not an actual cardiac critical care question, right? Because this patient clearly it is a more of a cardiology MCQ, but this is a direct taken up from the past papers of EDIC 1. So you can expect this question because cardiology they expect, and respiratory and neuro, basically the stroke management, they expect you to know even a bit of a more outside the very critical care part also, more word based or more OPT based question. So let's see, has somebody answered anything? You can write down in the chat box. Okay. So I shall just wait for a minute. So, uh, so they have given the option is no treatment necessary as a AF is short and self-terminating. So one way of answering this sort of question is what is the first line management is to rule it out. Regular beta adrenergic blocker, I think we know that it will not be the management because that is not a first line management for any of the cases of AF, right? Dioxin definitely not. Dioxin is not a first line management for these things. So one option is pick in the pocket flecainide, which even if we don't know, we shall think that maybe that is the answer. Regular amiodarone, this patient is a 76 years old, but now asymptomatic, so chemical cardioversion is possibly not needed, right? Because the patient did not feel palpitation this time. So rhythm control is, rate control is not needed. So either it's A or it's a B. No treatment because the AF is short and self-terminating. but it is a 10-minute run of AF, right? 10-minute run of AF. So it terminated after 10 minutes. Is there any minute-wise control? It's there. It's in the regular. If you go through the complete AF guidelines, it is a more than anything more than more than 6 minutes is it's a medical management. But even if we don't know, because that is a this duration of AF, that is a cardiologist domain basically. It is OPD based question. So 10-minute run of AF, even if you don't know about this, just by common sense, I think you can tell that 10-minute run of AF is possibly too much, right? So this will not be the answer, and this will be the answer. So if you know the answer, just fill in the pocket figure right. OPD based patient, OPD based treatment of AF. That's the obvious answer. But even if you don't know, that is how you come to the answer. You take it between two options, and then if those options are too similar to each other, you can just choose one. It's a 50-50 chance. It's a better chance if you are blindly choosing four options. So that's what I wanted to show to you guys. So I spent some time on this question. Next question. Again, you read and you tell me the answers or your choices in the option box. I mean, in the chat box. 2 minutes. Okay, because it's a long question, the EDIC actual exam. So it will take some, you need to read the questions fast. As I have told in the previous crash course and also in some of the regular classes also, in such a long stem, it's always better to start with the the options. So here the option is what is the best long-term management strategy? Defibrillator, EP testing, PCI, OPD based, and long-term amiodarone. So now we know it. So now let's see very quickly what's happening. So basically, the 66 years old man who has now come with palpitations and dizziness, hypertensive IHD history, AMI 6 months back, right? For which he had a stent to the LAD. On examination, his heart rate is 190. He's in VT. Blood pressure is 60/30. Respiratory rate, these things are given. No chest pain. Underwent emergency DC cardioversion. Sinus rhythm. His sinus rhythm now showed an evidence of old anterior infarct, which is obvious because they have told that there is an LAD block was there. Prop T was this, and now it has increased. And echocardiogram showed ejection fraction 35%. So basically, this gentleman had a VT which was cardioverted. Patient was like 190 beats and 60/30 BP, and the patient has a previous history of AMI. Troponin T is raised, and ejection fraction is 35%. We have not been given the past ejection fraction, right? So we don't know whether ejection fraction is lower than before or not. So now, what is the best long-term management strategy? So these options are for option A, this second question, right? Option A. So everybody is writing option A, and that is obviously the obvious answer. So it's gentleman with a past history of AMI, now VT. Thankfully, it reverted back, but the next best strategy, long-term strategies, of course, an ICD. So it's a pretty obvious answer. Okay, so it's an ECG-based question. Once again, always if there's an ECG is given, always analyze the ECG first, then read the answer question. So what is the ECG showing? I think it's pretty obvious what the ECG is showing. So it's a 34-year-old woman, palpitations, electrophysiologist for ablation. She had tried the Valsalva maneuver at home, but it had not worked. Vagal maneuver was also no effect. Heart rate 200, blood pressure is okay. So she is okay. So what is this? I think you guys are happening for 81, right? So it's an AF, right? It's an AF with an first ventricular rate. But the patient is not hemodynamically unstable. So let's see what they are expecting. This is the ECG as we have seen. So what is the best treatment now? So it's an AF with a fast ventricular rate and the patient is hemodynamically still stable. So Dr. Srikanth has told option B. We shall wait a few seconds, 30 seconds for the others, and then we shall continue. I don't know why it's coming repeatedly coming back here. So this question is basically between rate control versus rhythm control. So amiodarone is a chemical cardio defibrillator, as you know. I mean, this is not the answer. This is not the answer. This is not the answer. So those three, I think nobody is thinking of. This is between B or D. So B, IV amiodarone is there, and D, intravenous metoprolol. So as we know, there is no difference between rate control and rhythm control, right? And in this case, the patient has been awaiting for a ablation. It's an AFP first ventricular rate, but still if the patient was hemodynamically unstable, we would have gone for the cardioversion. If the patient had a long history, then again possibly amiodarone first, followed by a cardioversion, as you know, or a TE first to rule out the thrombus, then a cardioversion. Here we don't have to do those things because it's a straightforward, because the chronic history has not been given. If the history has not been given, we can assume that it's not a chronic case. And anyway, it's a 34-year-old lady. So maybe it's an acute onset. So we shall directly chemically cardiovert the patient. It's IV amiodarone is the obvious answer. Intravenous metoprolol can be the answer. When can it be the answer? If it's there was no fast ventricular rate, if the patient's heart rate was not too high, so there we can go for a metoprolol also. But metoprolol is usually not the first line agent. It's usually the intravenous amiodarone, especially in a critical care setting.